of Medicine in New Mexico with an MD in 1991. She attended residency in Duluth, Minnesota, where she became board certified in family medicine. She also achieved her board certification in addiction medicine in 2019 through the practice pathway. She works for El Centro Family Health in Española, New Mexico, where she is Chief Clinical Officer in addiction to seeing patients. While Dr. Hayes enjoys all aspects of family medicine, her passion is taking care of people with opioid use disorder. She especially enjoys working with pregnant women and new mothers who have had drug problems and works hard to make sure that they and their babies receive compassionate and appropriate medical care. She has done extensive teaching around the Project ECHO, New Mexico Bridge Project, and American Society of Addiction Medicine. She was named a White House Champion of Change in April of 2016 for her work with substance use disorder and pregnancy. Her work has also been featured in the documentary The Providers. With that, Dr. Hayes, please take it away.
All right. So, nuts and bolts of buprenorphine prescribing. And Dr. Gurule gave me some of the opioid receptor slides. At the end of this talk, I hope participants will be comfortable with the basics of evaluating a patient for buprenorphine, how to start buprenorphine and maintaining patients on buprenorphine, including what to do if there are problems. Residency faculty should feel comfortable that residents have covered the basics and have a plan to deal with any problems. Outline of talk: initial evaluation, buprenorphine induction, buprenorphine maintenance, dealing with bumps in the road, moving to a higher level of treatment, and frequently asked questions. Initial visit. So a few general tips for the initial visit: be compassionate, discuss confidentiality, including limits of confidentiality. And the limits, some of them include referral to Child Protective Services, need to notify emergency services if the patient is homicidal or suicide, insurance and court order. I always give the patient permission to not answer any questions they feel uncomfortable with. And I always think you want to start with the things with the least emotional impact. So you start with your basic medical history. Do they have a history of hypertension? Are they allergic to penicillin? Things like that. Next, you're going to ask the drug history. And save the questions about the consequences of drug use for the end once you've developed some rapport. And if you don't get rapport during that first visit and don't feel like maybe it's the best idea to be asking these questions, it's just fine to wait and do it later. Some general tips: if there's not adequate time to take a complete history, it's fine just to make sure the patient has an opioid use disorder, and you can trust them. If they come in saying they have an opioid use disorder, almost nobody's going to lie about this. That they want to quit using illicit opioids or other prescription opioids. They want to begin treatment with buprenorphine. They have a safe place to store the medication. And if they can become pregnant, confirm if they are pregnant or if they're using contraception. And then have them return for a more thorough history in the future. So drug use history, some of the things you want to ask: how old were they when they first used? What are they currently using? How are they using? How much are they using? How often are they using other drugs or alcohol? The reason they want to quit now is really important, and it can help to come back to that later. What's their rehab history? Are they currently doing counseling or meetings? Have they done them in the past? And if so, were they helpful? What did they really think was useful for them? What is their longest period drug-free, and how did they do it? For many patients, this is going to be incarceration, and unfortunately, that doesn't seem to help as far as long-term sobriety. Have they tried buprenorphine? Was it off the street or was it prescribed? How about methadone? And did methadone or buprenorphine work for the patient? Medical history, including chronic illnesses, psychiatric illnesses, surgeries, medications, allergies, vaccines. Always ask about HIV and hepatitis C. Ask about contraception and pregnancy. Ask about their living situation, who their partner is, and who's supportive in their life. And in particular, you want to check if their support system is using drugs. And is their support system supportive of them quitting? You might consider offering treatment to the people they live with or to their partner. It's really difficult for people to quit when people around them are using. So helping to find support for other people in their life to quit can be important. What's their employment history? Are they currently working? Do they have Narcan at home? Have they ever overdosed? Do they have children? And if so, are they living with the patient? This can be a super emotional topic for a lot of people. if they have lost custody. So you want to be kind about this. You never want to scold. And then also ask about the consequences of the drug use, any medical consequences, social or work consequences. And again, all of these can be really touchy. And if you don't feel you've got good enough rapport on that first visit, you do not have to ask these latter questions. So residents, make sure that they are talking kindly about the patient. If they're really derogatory or if they're complaining or really, judgmental about the patient, I would call them out on it. It's really important that they be talking kindly about these patients because it's going to come across to the patients. And make sure the things that are really essential at the first visit, make sure they've checked the PMP. Make sure that they've established the patient has an opioid use disorder. And again, patient report is fine for this. They've established that the patient wants to quit using opioids using buprenorphine. They've made sure the patient has a safe place to store the medication. If the patient can get pregnancy, they have ruled pregnancy out or in and offered contraception if not being used. And they have offered naloxone. The rest of the history is useful, but this is what's really important. Buprenorphine induction. A lot of patients are going to have already tried buprenorphine on their own and they'll feel comfortable with how to do it. If so, it's fine to give them a prescription and let them start if they feel comfortable. The traditional way to start buprenorphine involves putting the patient into withdrawal, having them start buprenorphine 12 to 24 hours later. And I mention this because you're still going to find this in a lot of sources. This is the way that's most likely to precipitate severe withdrawal. And so we don't recommend doing this anymore. I mention it mostly to tell you not to do this. So when you have a person who's physically dependent on opioids, here's what it looks like when they're taking the opioids. These little purple squares are opioids such as fentanyl. The little green square is buprenorphine. So you've got a person who's physiological dependent. They've got a full agonist on the receptor, releasing all of the dopamine. You come over here and you have the buprenorphine, which is going to release a little bit of the dopamine. And so you've got this dramatic drop in the level of dopamine here, and they're going to feel like they're in withdrawal. So what we've gone to then instead is low dose dosing. And this is off label, but it involves starting very small doses of buprenorphine while the patient is still using and gradually increasing. The patient usually stops using on their own when they reach a certain dose of buprenorphine. It's much better tolerated, seems to be especially helpful for people coming off fentanyl. There's a lot less research on this, but the research that has been done is favorable. It can be somewhat complicated. Some patients may not be able to do it. And you'll notice none of these three are quite the same, but anything is fine. You just want to start extremely low, generally a fourth of a 2 milligram tablet or film, and you gradually increase it. And if a patient has withdrawal symptoms, you can stop along the way. The two problems with this one, the first is it can be a little bit complicated. I have had patients who it's just too complicated and they can't figure it out. The second problem is I often find patients get to about here and they lose motivation. So this works really well if you have a motivated patient and you have someone who can check in with them frequently, but there can be some issues with making sure they finish it. So here's what the low dose dosing looks like. You've got over here on the left, all the receptors occupied. Over here on the right, you've just replaced one of the receptors with buprenorphine. So you've still got enough dopamine being released here that they're not going to feel like they're in withdrawal. So rapid low-dose dosing is similar to low-dose dosing. It is done much more rapidly, giving the dose every 4 hours rather than every day. And it's usually done in a hospital, which in New Mexico is only covered for pregnant patients. So macrodosing is the exact opposite. I've been told with starting buprenorphine, you either need to whisper or shout. And the low-dose dosing, or microdosing as it is also called, is the whispering. This is the shouting. So the macrodosing approach is you put them in pretty severe withdrawal and then start really large doses of the buprenorphine. So we don't recommend it for people where withdrawal might be dangerous. This includes significant medical problems. If they've got angina and you put them in withdrawal, it could precipitate a heart attack. Really severe mood or psychiatric conditions. Opioid withdrawal is pretty miserable. And if they've already are feeling somewhat suicidal, severe withdrawal could push them over the edge. Obesity is an issue because fentanyl is stored in the fat tissue. So even once they're in withdrawal, they may still have a significant amount of fentanyl in their body. And other substance use disorders or addictions, it can be very complex, and also can be hard for patients using high-dose fentanyl to do it this way. So with this, you want to have them wait at least 24, and I prefer 48 hours after the last time they've used fentanyl until they feel bad. They've got anxiety, restlessness, shaking, body aches, sweating, twitching, fatigue, yawning, runny nose, teary eyes, abdominal cramping, diarrhea, nausea. And you can consider giving them medications for the symptoms: ondansetron for nausea, gabapentin and hydroxyzine for anxiety, acetaminophen or nonsteroidals for pain, loperamide for diarrhea. So clonidine is on these slides. I am going to give you the warning that there was one non-published study that I saw, and I've never seen it repeated, which is too bad because I would like to, but where clonidine was found more frequently in fatal overdoses. And if you have an overdose, what happens is your breathing slows very far down, and you're going to get a compensatory tachycardia and hypertension. And so if you've got clonidine on board, it's going to block those compensatory mechanisms, and so you're going to be more likely to die from an overdose, at least in theory. I don't think it's really been proven yet, but I think it does need further study. So I really warn patients if I'm going to use clonidine about that risk. And basically, once they're far enough into withdrawal, you have them take 8 milligrams, let it completely dissolve, and then every 30 minutes, you give them another 8 milligrams until their symptoms of withdrawal have resolved. And this may take a lot of buprenorphine. My friends who do this in the emergency room tell me they've used up to 64 milligrams of buprenorphine to do this. Day 2, you begin putting 8 milligrams under the tongue 2 or 3 times a day. And if at any point during this whole process they feel really bad or any symptoms that make them worried, such as chest pain or suicidality, they need to go to the emergency room. So this is what it looks like. This is a person with opioid dependence. You've got a lot of the receptors unoccupied, so they're in pretty severe withdrawal. And you just slam a lot of buprenorphine and you put enough on that eventually you have all the receptors occupied and you can take them out of withdrawal. So tips for helping residents with induction. This is the most difficult part of treating patients with buprenorphine. And I'm going to say if this is not something that you as a faculty are comfortable doing on your own, it's reasonable to refer out for this. You don't want to be trying to learn with the residents because this is really quite complex. And if you're going to get anybody in real trouble with treating with buprenorphine, this is going to be it. So this usually requires a lot of education. It's very helpful to have a written handout. And I would actually recommend role-playing this with the resident and or supervising them the first few times that they do this, because the education is pretty extensive and you want to make sure they're covering everything important. Maintenance treatment. So some basics of the maintenance. First is the patient taking buprenorphine? Is it working for them? Are they having cravings or withdrawal symptoms, or do they feel pretty good on it? Do they have any side effects? The most common side effects include constipation, nausea or swelling in the hands or feet, cravings, and like I said, ask about cravings and withdrawal symptoms. Ask about drug use, and if they answer yes, you want to find out what happened. What was the trigger? And I always like to I think it's really helpful to determine if it's internal, something such as anxiety, or external, a friend showed up with drugs, or a combination. They had a fight with their family, they got really stressed, and that led to relapse. And depending on what it is where you're going to focus your energy. If it's internal, they have a lot of anxiety. Maybe you need to think about an SSRI. Maybe getting them on counseling will be helpful. If it's a friend showing up with drugs, is there a way they can avoid that friend? Do they need to find new housing? So depending on what it is going to determine your response. Which drug did they use? And did they get a response? If they're on an adequate dose of buprenorphine, they should not get a high from an opioid. And if they're getting high, it may mean either they're skipping doses, in which case we need to talk about that, or they're not on enough medication. And always forget to put this in. Do they want to quit using? I have had patients who are very happy to be on buprenorphine because they're no longer using fentanyl, but they are perfectly happy to continue using cocaine. It would not be my choice for what I recommend, but If that is what they want and they're happy with it, then I don't think spending a lot of time coming up with a plan is necessarily going to be helpful. But most patients are going to want to quit all of the drugs, and so working with them on a plan to avoid using in the future. I always ask separately about alcohol. Many people do not consider this a drug, but I find alcohol is actually the most common drug that people are using. Storage, really essential that the medications be locked and hidden. If there are small children in the house, it needs to be stored so that children cannot get into it. Tiny amounts of buprenorphine can kill a toddler. I had a patient, and she gave me permission to tell this story, and her toddler was okay. However, she was taking her buprenorphine, and the phone rang. She turned away to answer the phone and turned back, and in that amount of time, her toddler had grabbed the pill bottle. She grabbed it out of the hands and counted. All the pills were in there. And so we assume what must have happened is the toddler got powder on her fingers and put her fingers in her mouth. Tiny, tiny amount. They watched her for 6 hours until bedtime, and she was fine. They took her to bed with them that night so that they could continue to watch her. 12 hours later, the toddler stopped breathing. The parents did CPR and called 911 and got her to an emergency room where she was fine. But take-home message. Tiny amounts of buprenorphine are extremely dangerous for toddlers. They need to have it locked so the toddlers cannot get into it, and they need to take it in a locked room away from the kids. I always ask if they have Narcan at home, and I always ask about contraception if they are someone who can get pregnant. 88% of pregnancies in women with opioid use disorder are unplanned. General functioning. Are they attending meetings or counseling? And if so, are they useful? Are they using seatbelts? I think this is a really important one. There was one study that looked at women who had a baby with neonatal opioid withdrawal syndrome, and what they found was a 10 times higher rate of death from car accidents in women with opioid use disorder who had had a baby with neonatal opioid withdrawal syndrome than in women who did not have a baby with neonatal opioid withdrawal syndrome. So I think it's really important we ask about seatbelts. And then employment. What's their living situation? Are there other people in the household using drugs? Is the living situation a supportive one for patient? Who's supportive in their life? Do they have friends or family that they can turn to if they need help? Often their whole support system is using drugs and they don't want to go to that support system, so helping them identify other people who might be supportive of them is important. Are they having any anxiety or depression? And how are they sleeping? Urine drug screens. So until COVID, we checked urine drug screens with every visit. Now we're often checking them every 6 months or more. By law in New Mexico, you're supposed to check anybody on controlled substances. You're supposed to check a urine drug screen every 6 months. So there's a growing trend towards not checking at all, as it implies you don't trust the patient. I do recommend checking often enough to stay in compliance with your license for sure. So if you're going to use drug screens, though, it's really essential to use them correctly. It's really helpful to have in-office tests. That way you can get the results within about 5 minutes and you can talk about it with the patient right away. They're also extremely cheap and easy, but it's really important to remember these are not super accurate. They're useful as a general tool in monitoring progress, but you have to understand the limitations. So if you get an unexpected result on a urine drug screen, you need to confirm it. The easiest way to confirm it is to walk in the room and say, hey, your urine drug screen is showing up positive for cocaine today. And a good percentage of the time, if you've got a good relationship with them, they'll look at you and say, yeah, I used cocaine at a party this weekend. Boom, you've confirmed it. You don't need to do any further testing. But if you walk in the room and the patient says, I don't understand how that could be, I have not used cocaine, then you really need to send out for GCMS or LMS testing. I have seen patients lose custody of children over in-house tests that I'm pretty sure were false positives. I have seen people go back to jail while waiting for these results. You really need to confirm any results. And some limitations of the urine drug screens. The tests do not tell you when the patient used. The tests do not tell you how often or how much they are using. The tests don't tell you how they used. You don't know if they took the oxycodone pill as prescribed or if they snorted 6 of them. And an opiate test is not going to test for oxycodone. You need a specific test for oxycodone. Synthetic opioids such as fentanyl or methadone will never be detected on an opiate test. So buprenorphine requires a specific test. Fentanyl, methadone, and oxycodone all require their own test. They will not show up on an opiate test. Most importantly, the tests do not tell you the patient's level of commitment to getting drug-free. Too often, patients will see, or providers will see, oh, the patient has methamphetamine on board, and think, oh, they don't really care about this. I might as well just stop their Suboxone. That is not at all the case. I've seen plenty of patients who really struggled the first year with multiple positives, and then finally, at the end of a year, they are ready to, they've gotten enough on track in their life that they're able to completely quit. So just because there's a positive on a urine drug screen does not mean that the patient is not committed to getting drug-free. And I'm going to talk real quick about buprenorphine metabolites. Buprenorphine is metabolized into norbuprenorphine, which is metabolized into norbuprenorphine glucuronide, and it's also metabolized into buprenorphine glucuronide. The three metabolites are water soluble, so whereas the parent drug is minimally water soluble. So sometimes patients will put a tablet of buprenorphine in the urine because the urine would not otherwise have buprenorphine. It may be because they are not using buprenorphine and they have weaned off. It may be because they're using buprenorphine, they're not using buprenorphine and they're using other opioids. It may be because they brought in someone else's urine. You can't really tell. The in-office test will show positive for buprenorphine, either if the patient puts a tablet in their urine or if they're taking the buprenorphine properly. The confirmatory test is going to show the levels of each of the metabolites. So again, parent drug is buprenorphine. This is minimally water soluble, will be in low levels in the urine. The metabolites are buprenorphine glucuronide, norbuprenorphine glucuronide, and norbuprenorphine. These are much more water soluble. These should be found at high levels. So if the patient is taking buprenorphine, there should be high levels of buprenorphine metabolites and low levels of the parent drug. If the patient put a tablet in their urine, there will be high levels of the parent drug buprenorphine, no or minimal metabolites. Some labs will show all four separately, and then some will group the two buprenorphines and the two norbuprenorphines together. If the lab lists all four separately, the buprenorphine level is going to be low, the other three will be high. If the lab groups them together, both the buprenorphine and the norbuprenorphine will be high. Seriously though, consider doing urine drug tests only as required by law in maintenance, except in very special circumstances. The goal should be that we are establishing a good enough relationship with our patients that they feel comfortable telling us about this, and they're going to feel less likely to be comfortable if they know we are saying we don't trust them by doing regular urine drug tests. So you really want to think about why you're doing the urine drug test. Special circumstances, I think it's a good idea to do it when you start, just so you know what they've got on board. I think it's a good idea to do it if they tell you that they've taken something and they don't feel right. They thought they were getting methamphetamine, but it left them feeling really weird. And if they come into the hospital and they're unconscious, that's a good time to do a urine drug test. But seriously, think about whether or not you want to be doing urine drug tests on a regular basis, as it does give a message to our patients that we don't trust them, and it's going to make it harder to establish that level of comfort that's so important for these patients. So, tips for evaluating residents on follow-up visits. The following are essential for follow-up visits. Make sure they have done these. PMP, and again, urine drug screen required by medical board every 6 months for patients on controlled substances. Make sure that they know how to interpret the results correctly, including knowing when they should send it out for confirmatory testing. The resident should have asked if the patient is taking buprenorphine, if it's helpful, and if there's side effects. They should have asked if they've used drugs, and if so, do they want to stop and what their plan is. They need to ask about meetings or counseling, and is it helpful, and does the patient want to start? They really essential they ask about safe storage of medication. If I have only time to ask 3 questions, storage of medication is going to be one of them. Are they using contraception if they can get pregnant and don't want to get pregnant? And do they have naloxone? And the other thing, make sure they're following up on other chronic conditions and preventative health. One of the really great things about prescribing buprenorphine is we get a population of patients into the clinic who may not be following up on getting their pap smears and may not have been doing treatment for their high blood pressure. So this is a really great time to make sure we're getting all that other medical care we need. It can be really easy to get so focused on the buprenorphine that we want to do this. And obviously you don't want to do this in the first couple months when they're still trying to get on and they're kind of unstable. But once they're stable, really, that's a great time to do the preventative health. Also, these patients can be really challenging, and residents may react very emotionally to them. They can be very angry at the patients if they've relapsed. They can also be very angry if they've lied. And I think we need to accept that patients lie to us sometimes and not take it personally. They can also get very sad about things that happen. And they may become overly invested in the patients. And just make sure that they're protecting their boundaries and make sure they don't take relapses personally. That's very, very common when people first started treating these patients. And the other thing to realize is that they may lose patients to overdose. If you take care of enough of these patients, you're going to lose patients to overdose, which can be just devastating. And I think it's really important that they have somebody they can talk to about it if they want. Dealing with bumps in the road. First bump, very common. Patient is using non-prescribed drugs. So don't shame the patient. Most of the time, the patient is already quite ashamed of using. Many are very worried about disappointing us. Encourage the patient to be truthful. Relapses happen in addiction, just like they happen in heart failure or cancer. And we really want to focus on what are the problems with the treatment plan? How can we make it better? Do they need counseling? Do they need peer support? Is their dose of buprenorphine too low? Was it a one-time thing and we don't need to worry about it? So ask questions about what happened to the patient that they ended up using. Find out the circumstances of use. Again, find out if they need counseling or more support. What about patients who will not acknowledge use even though we have reason to think they have used? Their routine drug screen showed up positive for methamphetamine. So because of shame, many patients are not going to acknowledge use. They also may be worried that their buprenorphine is going to be discontinued. So as clinicians, I understand. I want all my patients to tell me the truth all the time. It doesn't always happen. And I think we need to accept that this is going to happen. It doesn't mean that we are bad doctors. It doesn't mean that the patient is a bad patient. It is just what happens in family medicine. So continued use is a sign that withdrawal symptoms or cravings are not controlled. And so we need to really focus on the treatment plan. So, and every clinician is allowed to determine their own level of comfort with this. There are some people I've worked with who have just said they don't want to work with patients who are lying, in which case they're probably in trouble in family medicine in general. But I think people can determine their own level of comfort, but I would encourage you to be comfortable with patients who are continuing to use. And you want to try and cultivate a relationship where the patient is going to feel comfortable talking about this. And most patients with substance use disorder have been lying about their use to others and to themselves for many, many years. It may take more than a few visits for them to feel comfortable talking with you about it. And again, my patient is lying. It's helpful to remember a lot of our patients are not always truthful. And people have this image that the substance use disorder patients lie and none of the rest of our patients do, which is just unfortunately not true. I have patients on blood pressure medications who tell me they are taking them every day and they haven't filled them since last January. They're not always honest about what they're eating or how much they're exercising. And we understand in general that patients are sometimes less than truthful because they're embarrassed or worried we won't like them. And we need to extend grace to all our patients in these circumstances. Abnormal urine buprenorphine results or metabolites. This is really tricky. I think it's really important to discuss what the results showed. The patient may or may not acknowledge that they put a pill in their urine. I remember one time telling a patient about this and he looked at me, he's like, wow, I did not know you could tell that. And I'm like, yeah, we can. He's like, yeah, I put it in. So you want to discuss the circumstances if they will acknowledge it, discuss why it happened. If they don't acknowledge it, I still make it clear this is what the results showed. It can't happen again. If they have recurrent urine drug screens that are negative, you need to reevaluate treatment. Do they really need the buprenorphine or other treatment? If yes, injectable buprenorphine is a great one because then you know for sure they're getting it. Methadone or inpatient. Treatment of pain in patients on buprenorphine. So people with opioid use disorder deserve treatment for their pain just as much as any other patient does. I have a patient who has been stable on methadone for 10 years. She had complications from a surgery, and when she went into the emergency room nurse, when she found out she was on methadone, looked at her and said, "You just forfeited any right to pain control in this emergency room," which is terrible. I mean, this woman was on good treatment and doing well and was having a significant complication to her surgery. So, as with all patients, we want to maximize non-opioid treatments, non-steroidals, acetaminophen, gabapentin and pregabalin, duloxetine, venlafaxine, and milnacipran, physical therapy, acupuncture, therapeutic injections, and mindfulness. If the pain does not get better by the above, you can try increasing the daily dose of buprenorphine to 24 milligrams. And I don't fully understand what's happening in the brain, but for some reason, buprenorphine works much better for pain if you split the dose every 4 hours. For opioid use disorder, you're fine once, maybe twice a day, but for this, you really need to be taking it regularly. If the pain is acute and not relieved by the above measures, you can prescribe opioids on top of the buprenorphine. Make it clear it's a short-term measure only. If the pain is chronic and not improved by the above measures, consider referring the patient to a methadone clinic. However, methadone in a methadone clinic is not dosed to provide good pain relief. It's almost always dosed once a day, and similar to buprenorphine, you really need split dosing. However, I have had patients who get really great pain relief even on the once a day. There also can be a little bit of a delay in getting them started on methadone and getting to a therapeutic dose. Under no circumstances should a clinician ever put a patient they've been treating with buprenorphine on methadone. This may be viewed as you treating the opioid use disorder with methadone, which is a violation of federal law. Even if you think to yourself, well, I'm using it for pain, the DEA, if they decide you are using it to treat their opioid use disorder, you're going to be in deep trouble. Early refills. Ask the patient why they need an early refill. If they're overtaking, maybe their dose is just too low and adjust if needed. This is the most common reason. And, most of the patients I've done this have done well. If they've lost their prescription or had it stolen, they absolutely need to make sure to take steps to keep it from happening again. I will do a refill the first time this happens, but if it happens repeatedly, they need to take steps to prevent it from happening. They may need more frequent visits or shorter prescriptions. I had one patient who was overtaking every month, and then he'd run out a week and a half early. And so we just ended up giving him week-long prescriptions with 3 refills. And, first off, when he would look at the bottle and realize, this is all the pills I have to last until the end of the week, he was definitely better about not overtaking them. But even if he did overtake them, it was usually only a day or two until he could get his new script. So it really helped a lot. Missed appointments. If it's a one-time occurrence, send in a script for a few days and reschedule the appointment. If it's recurrent, figure out why. Lack of transportation, really common in New Mexico. So see if they're eligible for transportation through Medicaid. Medicaid will provide non-emergent transport to appointments with 72 hours notice. It's been a little flaky since the pandemic and has not improved even as things got better, but it's a possibility. Poor phone service is really common in New Mexico. I've had plenty of people miss telehealth visits because their phone just never rang. Poor executive function with this organization. This is really common in patients with substance use disorder, and counseling or matrix groups can often help with this. Shame or embarrassment about having relapsed and fear of being scolded if they come in. Try to be compassionate if they've relapsed. If they know you're not going to yell at them, they're going to be much more likely to come in. And fear of medical appointments or history of medical trauma is very common in this group. Refer for counseling. Last is lack of commitment to treatment. And this can occur, but it's really important to rule out the other things. I see too often that providers see a patient has missed appointments and they say, oh, well, they clearly don't care about getting drug-free and just giving up on them. But the fact that they're showing up at all is really a huge step, and we want to do what we can to encourage them. Pregnancy, really important. Do not stop buprenorphine. If you're not comfortable with management, arrange for a transfer to a prescriber who is comfortable, and write for a script with a buprenorphine without naloxone long enough to last until they have an appointment at the same dose you've been prescribing. Send in a prescription for prenatal vitamins. Make a referral for prenatal care if you're not going to be providing it yourself. If you've done all of this, you've done better than the vast majority of providers in the United States. Make sure residents have a plan for dealing with bumps in the road. Make sure they know that this is part of treating any chronic disease, not a sign that treatment is not working. It's just a sign we need to increase treatment. So, moving to a higher level of treatment. Consider moving to a higher level of treatment if the patient is continuing to use opioids while on buprenorphine and you've optimized the dose. The patient should be involved in this decision. For some patients, using heroin or fentanyl once a week is the best they've done in years, and they are happy with that. I had a patient who started using heroin when he was, something like 12, and he continued to use it until he was 50 and got on buprenorphine. He continued to use heroin once a week for the next 10 years, and he was so proud of himself. He just kept telling me, I never thought I'd do this well. I never thought I'd be able to stop using heroin at all. I've had other patients who use one time, and they are arranging to get inpatient treatment. So possible higher levels of treatment, injectable buprenorphine. Injectable buprenorphine is useful for patients who get really good relief of their cravings and withdrawal symptoms, but it's just not enough to completely stop using. This is much more common in the fentanyl era. It's also useful for patients who struggle to take a pill every day. It's really especially useful for patients who are super motivated to stop on Tuesday when they're in the office, but then they skip doses in between visits so they can use. It's also a good option if the patient doesn't have a good place to store medication, especially if there are children in the house. And it can also be a good option if you're concerned about diversion. I've had a couple patients who were definitely diverting their meds, but they were also taking it. And when I stopped it, they relapsed and did not do well. And this was before this was an option that was available. Methadone can be really useful in patients who have chronic pain not relieved by buprenorphine. It's good in patients who are really not getting good relief of cravings and withdrawal symptoms on buprenorphine. And there's also a lot more structure in a methadone clinic, and it can be very useful because of that. And we want to consider inpatient treatment in patients with significant psychosocial dysfunction, housing issues, continuing to use despite medication, or use of multiple drugs. Discontinuing treatment. The following are not recommended as reasons to discontinue treatment: pregnancy, urine drug screens positive for illicit drugs, patient has been on buprenorphine a certain length of time, and be really cautious about discontinuing medication early in treatment. Often when people first start on buprenorphine, they just want to not be taking anything, and so they'll try and stop right away, and unfortunately the rates of relapse are really unacceptably high if you discontinue it at that time. So rapid discontinuation or detox is done frequently. It's rarely successful in getting long-term sobriety unless they really get intensive psychosocial treatment. And it actually can increase a patient's overdose risk because they'll have decreased tolerance and they may abruptly return to use because they're not having anything to decrease cravings. So it's really recommended only in very specific circumstances, such as a patient going into incarceration or an abstinence-based program. And basically, you're going to start at 8 milligrams, do that for 8 milligrams twice daily, a couple days, then 6 milligrams twice daily, 8 milligrams daily, and you're gradually going to go down over about 2 weeks. Gradual discontinuation is really much, much better. And this is for patients whose opioid use disorder is stable, they want to get off the medication, they're at lower risk for return to use or relapse. So you want to evaluate their stability overall, including their living situation, their sources of support, how often they're relapsing, any psychiatric or medical comorbidities, and their commitment to getting off. And what I recommend is decrease by half a tablet every other day, Monday, Wednesday, Friday, for 2 to 4 weeks. You continue them on their full dose on Saturday, Sunday, Tuesday, Thursday. And then once they're stable, 2 to 4 weeks, they're not having any cravings or withdrawal symptoms, then cut back to by half a tablet every single day. And then you just repeat this process for as long as it takes. So almost everybody's going to get mild withdrawal symptoms. These are common. They're generally going to get better without any problem. Cravings are more worrisome. If the patient is getting a lot of cravings, I really discuss with them whether they want to continue this with the weaning. And you need to involve patients in the decision-making. They may hit plateaus. The last few decreases are the hardest. And it's really important to talk about the risk of relapse and make sure that they understand this is not a failure on their part. This is just how the disease works. And if they do relapse, they're going to have decreased tolerance, so they need to use not nearly as much as they used to use. Make sure they have Narcan. Make sure they know they can restart buprenorphine if they need to. and think about placing them on long-acting injectable naltrexone to provide a little bit of a safety net. Frequently asked questions. Traditionally, we started at 12 to 16 milligrams a day. Oh, what dose should I use? How much is too much? Traditionally, we started at 12 to 16. With fentanyl use, it's not uncommon to have them need 24 to 32. You want to check in with the patient within 1 to 3 days to make sure their dose is adequate. Higher doses than 24 milligrams have not been well studied, but the studies that have been done have really shown pretty good benefit at doses above 24 milligrams. However, unfortunately, most outpatient programs limit you to 24 milligrams a day. So for patients who really need doses more than 24 milligrams a day, you can change them to an injectable formulation. You can refer them to an outpatient treatment program, such as a methadone clinic, either for methadone or sometimes they can do daily observed dosing and will be allowed to dose at higher doses. Most insurance plans in New Mexico will not fill prescriptions above 24 milligrams a day. I have one patient on 32 milligrams a day. Every month I write for 24 milligrams a day that her insurance will cover and 8 milligrams that she buys herself. Every month the pharmacist from both pharmacies calls to say, do you know she's getting medication from a different pharmacy? Because she gets the one at a pharmacy, the 24 milligrams at a pharmacy that's covered by her insurance, but for self-pay, the dose is cheaper at a pharmacy not covered by her insurance. So it's we're going to do it because this is what is working for her and keeping her drug-free. Tablets or films, patients are often going to have a very strong preference, and it may be determined by their insurance coverage. Often the insurers prefer the tablets. These are a little bit lower cost, but if all else is equal, use the films just because in the little containers, they're less likely to have kids get into them. If the patient wants tablets, that's fine. Doesn't really matter. How often should I see the patients? Initially, we usually see them weekly for the first 4 weeks, then every 2 to 4 weeks for 4 to 8 weeks, and then monthly. After a year, I'll go to every other month. And if this patient is struggling, you want to bring them in more frequently. But it doesn't have to be the physician seeing them. Often I'll just have them see our peer support worker or a counselor, and that works just as well. My patient's urine is negative for opiates. Can I still start buprenorphine? If there's a history of opioid use disorder and the patient is concerned about relapse, definitely you can start buprenorphine. So common situations are patients coming out of incarceration. These patients have such a high risk of relapse, absolutely indicated to put them on buprenorphine if they needed. Patients coming out of abstinence-based inpatient programs. Also, patients with opioid use disorder are undergoing stressful life events. I have had more than one person come in saying, I've got, 5 years sobriety, but my mother just died and I'm really worried I'm going to relapse. Again, patients rarely lie about having an opioid use disorder. Nobody wants this in their medical record. And also, again, understand the limits of point of care urine drug screens. Opiate test is going to detect heroin, morphine, codone, hydromorphone, and maybe hydrocodone if the patient uses enough hydrocodone. It's probably not going to detect oxycodone. It will never detect methadone, fentanyl, or buprenorphine unless you have a specific test for these. Should I require counseling? It is not recommended to withhold buprenorphine prescriptions if patients are not participating in counseling. Buprenorphine has really good evidence with or without counseling, and it is a life-saving medication. We don't want to withhold it. But almost all these patients are going to have significant psychosocial dysfunction. A good percentage are going to have co-occurring mental health conditions. They're going to really benefit from counseling or meeting or peer support. And I think we want to do everything we can to get them to attend counseling or meetings. We want to allow more time between appointments for patients who are attending. Contingency management will really help. Discuss regularly with the patients what they would find helpful and know the local resources for patients. My patient is using benzos or alcohol. Is this a contraindication to using buprenorphine? So the use of benzos or alcohol is actually much more dangerous in combination with heroin, fentanyl, or opioid pain pills. The FDA recommends prescribing buprenorphine in this situation, but monitoring carefully. So you want to evaluate them for benzo use disorder and alcohol use disorder. If they're present, you might want to add medication treatment for the alcohol use disorder, gabapentin, acamprosate, or topiramate. You might take over the benzo prescribing if they're getting them from another provider with the goal of treating the benzo use disorder and gradually weaning down their benzo doses. really, if at all possible, discontinuing alprazolam and transitioning them to clonazepam or diazepam. This can be a hard sell. I do understand this. You can also use gabapentin to stop the benzos more rapidly if you really feel they're not safe with them. And really important to connect to psychosocial treatment for both. How do I make sure my patient is not selling or diverting their medication? You can't prevent this 100%. There are some basic steps to take. One, make it clear from the start this is unacceptable and will result in discontinuation of buprenorphine. Two, check the urine for buprenorphine metabolites. Three, consider pill counts if there's a concern. Four, use the combination product unless there's a reason not to. Five, if there's a strong concern the patient is diverting, but they also seem to do well on buprenorphine, change them to the injectable formulation. So take-home messages. It's reasonable to start buprenorphine on any patient who has an opioid use disorder and wants to use buprenorphine to get off it. Once a patient has started buprenorphine, the most important things to check are that they're taking the buprenorphine, it's helpful for them, any side effects and safety issues, including Narcan storage and use of other substances. And there will be problems that arise for many patients. Most of the time, the buprenorphine can be continued, possibly with some changes. And that is all I have.
You mentioned that, some residents might become affected. So what would you say would be, what are some strategies, I guess, that are available that teaching faculty can use to support residents who are impacted by the death, of a patient?
So let me just start with, we'll start with if residents are strongly affected by a death, I would refer them for counseling. I mean, I think that they should get into counseling at that point because it can be a really significant event because often these patients are going to be quite young, maybe the same age as the resident, and that can be very hard to deal with. For patients who are just sort of becoming overly involved emotionally in it, I think it's really important to just talk about it being part of the disease process and not something directly against the resident, because residents and physicians in general, I think, often have this idea that if we do a good enough job taking care of the patient, that the patient is going to do everything they're supposed to do. And unfortunately, that is just not the case. We all know that many patients who we have a really good relationship with and, really like us still don't take their blood pressure medication. And so I think it's really important to let people know this is part of the disease process and, talk about that. And I think the other thing is, and I didn't have time to really go into this in here, but I think teaching good communication skills is really essential because I think, I spent so much time learning biochemistry and the minutiae of anatomy, which were really not that useful. And I didn't learn a lot of the communication skills that have really been much more useful in my profession. So teaching residents motivational interviewing skills and teaching them things about how to break bad news compassionately and teaching them these communication skills is really essential. And I think once you've started improving the communication skills, then you're going to focus less on, first off, the other thing is trauma-informed care, I think is also really important. And if residents are able to do these communication skills and realize that this is part of the disease process rather than a failing on their part, I think it'll help them to establish those boundaries, but still be able to provide kind and compassionate care. Because I think people often feel like, having boundaries means that they can't be compassionate to the patients, whereas it's the exact opposite. I think if you have good boundaries, it's easier to be compassionate without, kind of destroying yourself emotionally. So.
And jumping off the communication part, what would you say would be maybe the foundation of starting, that getting into learning communication or health communication?
I would start with motivational interviewing.
Okay.
I think that's just it's really useful. It was developed for substance use disorder, but it's really useful for almost any patient you see. And the idea is rather than us forcing what we want on the patient, figuring out what the patient wants, which is actually the same as what we want a lot of the time, but sometimes it's not. And realizing, being able to ask the question so that you know what the patient really wants is often very helpful to being able to kind of say, okay, I can let this go because even what I want is for them to completely stop using. What they want is to be able to, cut back on their use enough that they can see their grandkids twice a week or something like that. And so I think learning those communication skills will really make a difference. So
Thank you.
Yeah, thank you for that. One of my questions I had was any best ways to integrate this teaching into residency programs, and I think that's a good start. With motivational interviewing and all those things.
yeah.
I did have another question.
Yes.
Those faculty and residents that might be hesitant to working with these types of patients, maybe never been introduced to this type of. Do you have any words of advice or thoughts around this? Just getting started.
Sure. So the first thing I'm going to say is most providers who do this on a regular basis will tell you that this is actually the most enjoyable part of their practice. I always like to say I have been treating hypertension for 35 years now. I have never once had someone come into my office and say, "Thank you, Dr. Hayes, for getting my blood pressure under 120/80. I really appreciate that." It just doesn't happen, but with treating opioid use disorder, you just make such an incredible difference in people's lives. They're so grateful. They're so happy. And it's really very gratifying work. I think for many of us, we've only seen patients with opioid use disorder in crisis situations in the ER where they're often not necessarily the most pleasant patients to take care of because opioid withdrawal is just so miserable. But when people start taking care of these patients in the outpatient world and realizing what a difference you can make, people really do discover it's a very satisfying group to take care of. And it's really not that complicated. It's far less complicated than insulin or GLP-1s for diabetes or any of that. It's a fairly straightforward medication other than the induction part. So I really encourage people just to give it a try because it is a very fun thing to do in medicine.
Dr. Hayes, are you able to share just an example of a success story or just something of impact?
Sure. I have let's see. I have so many. It's hard to come up with. So I have a patient who well, I mean, I gave the example in the talk of the gentleman who had used from the time he was 12 until he was about 50, and then, had 10 years drug-free, and unfortunately did eventually die of an overdose. But during that 10 years he was drug-free, he reconnected with his family. He got a really good relationship with his daughter. He was able to spend time with his grandchildren. He, started a relationship that he was really happy in. His health was so much better and he just felt better overall. And like I said, he was really happy. And this is not necessarily somebody that for many people they would think of as a success story because he was never able to return to work. He never completely quit using, but it made such a difference in his quality of life. And he was so grateful for the treatment. So.
Thank you so much for that. Yeah. Mario, unless you have any other questions at this point, do you think it'd be okay to just close it out?
I think so.
Okay, great.
Thank you so much, Dr. Hayes. Again, I really appreciate your talk on such a great topic. Thank you so much.
You're welcome. Have a great day. Bye-bye.